Right. Well, thank you everyone for taking the time to join us for our fourth Lunch and Learn session of the year. I'm Nikki Kinloch, I'm the CEO of Cure Cancer, and it's a pleasure to be here on somewhat cold and miserable day in Sydney. I hope it's better wherever you're listening in from as well. Today we have the pleasure of talking to Dr. Taskeen Janjua, who is based at the School of Pharmacy at the University of Queensland. Our session will last around 45 minutes. So if you do have any questions, there's a little chat box at the bottom of the call and you can type those questions in there. You can either direct them to everyone or to myself specifically, and I can weave those into the conversation as we go. So what are we going to talk about today? So glioblastoma is sadly a very aggressive type of brain cancer. It has a poor prognosis with a 5-year survival rate of below 5%. It's incredibly difficult to treat because few chemotherapies can enter the blood-brain barrier, and that's a protective shield around the brain that allows vital substances to enter while blocking harmful agents. One of the chemotherapies used for glioblastoma is TMZ, but the effectiveness of this drug is limited as it can't stay in the blood very long. It has low tumor penetration and is also prone to resistance. Dr. Taskeen has developed an ultra-small nanoparticle that aids existing approved drugs like TMZ to cross the blood-brain barrier and provide a more efficient targeted delivery of therapies for glioblastoma. So first of all, welcome Taskeen.
Thank you. Thank you for having me.
Pleasure, absolute pleasure. So before we talk about glioblastoma and the incredible work you're doing, can you just give everyone a bit of a background about who is Taskeen? What's your background and how did you get into cancer research in the first place?
So I started my academic journey in Auckland. So I went to University of Auckland and I trained to become a community pharmacist. And I did that for 1 year. And then I thought, okay, I need a bit more challenge. At that same time, my cousin got neuroblastoma, which is a different type of cancer. But it kind of changed my worldview on things. And I wanted to do a bit more research. I also had an opportunity when I was in university to do a bit of research in 3D printing formulations, and that kind of got me very curious to research. And while I was doing my internship, training to become a pharmacist, I applied for this research position opened up, and somebody told me about it, and I wanted to do a bit of a OE as well, so leave home. And so when this opportunity came along, I was very excited. And so I finished my doctorate in February 2023. And yeah, I think there's two parts to this research. One was personally motivated. I think we've all got family and members who've been affected by cancer. But the other was it's a very difficult challenge, and brain cancers, the drugs are very unlikely to go into the brain, and then when they even enter the brain, they are hard to enter into the cancer. And so that was a challenge I wanted to take on, and it seemed very interesting to me. When I started working on it, it became a very tricky. So I'll talk a little bit more about that later.
Yeah, look, absolutely. And I mean, we've funded researchers on neuroblastoma and actually on some glio as well. And we know how difficult it is. But I mean, at least with neuroblastoma, it's got a higher survival rate and it's much easier to treat because it tends to be one tumor as well, whereas glioblastoma is much more difficult. Could you just give everyone a bit of a background on what a glioblastoma tumor is, where it's found in the brain, and just a bit of a description there for people that may not be familiar with glioblastoma?
Yes, certainly. Glioblastoma is a very aggressive cancer of the brain. It's found all over the brain. It's not a specific location. And depending on the location where it is, it can be very hard to treat because surgery cannot be an option sometimes, if it's not somewhere you can resect. And sorry, what was the other thing you asked?
So it's all over the brain. I think one of the surgeons I spoke to a few months ago said it's a bit like having sand, isn't it? It's multiple tumors in the brain.
And it's quite resistant to a lot of therapies, and often it's diagnosed quite late. So that means that surgery is not an easy option because it's quite a big tumor sometimes. And so, yeah, and it occurs de novo, like, which means it just occurs as a primary tumor without any history. And typically patients have not a lot of, they are very generic sort of symptoms. You know, you can get confusion, some sort of memory deficit, sometimes changes to personality, headaches, seizure. It's kind of a mixed sort of a presentation as well. But it's a very frequently occurring brain tumor. So it accounts for 60% of all brain tumors in adults. And it also affects pediatric, like children as well. So it accounts for 3% of all brain tumors in children.
That's incredible. So, I mean, 60% of adults, and you're just thinking about this, if it's got less than 5% survival rate over 5 years, I mean, that's just a terrible prognosis, isn't it? In my introduction, I talked about the blood, the barrier around the brain. Can you explain a bit about that, why it's there, and also how that has caused you a challenge or two in your research?
No, yeah. So the main problem, compared to other cancers, blood-brain barrier is the main challenge with treating with treating brain cancers, because blood-brain barrier is a very important part of our body. It's a selective membrane that separates the circulation of blood from the circulation that's in the brain. So it plays a crucial role in protecting the brain from harmful substances, but it also allows essential nutrients to pass through. So it's kind of like a double-edged sword. It's very highly regulated, and it's made up of many cells. If somebody's interested, it's made up of endothelial cells, which are basically very tightly connected and packed together, which means that cancer therapies cannot enter the brain. And even if they do enter the brain, our blood-brain barrier is evolved that it will push it out. It's basically like if you eat a toxin, our bodies don't want that toxin to enter our brain. So similarly, chemotherapies or cancer therapies are no-go. They don't go into the brain. And even if they do pass through, they will be pushed out, which is called efflux.
So essentially, that barrier is doing what it should be doing. It is stopping toxins coming in, which obviously the chemotherapy is a toxin. So it's the body just responding as it should do, but unfortunately not beneficial when you're trying to treat something like glioblastoma.
Exactly. And then on top of that, the cancer itself, the glioblastoma, has also evolved these features. So if the chemotherapy gets into the cancer, it will just push it out. It will efflux it out. And that means that you have two barriers to cross. You have to cross the blood-brain barrier, and then you have to cross the cancer barrier. Whereas in other cancers, say for instance breast cancer or other cancer, it's just a single barrier. It's the cancer barrier that you have to permeate. So it's a double challenge essentially.
Yeah, absolutely. And we talked about chemotherapy. And we do have obviously some treatments for glioblastoma at the moment. Can you just talk about what they are at the moment, and why they don't really work apart from this barrier as well?
So typically when a patient gets diagnosed, if it's possible, the surgeons will try to remove the cancer. And then at the time of the surgery, they could leave an implant in the brain, so it slowly diffuses a drug, chemotherapy, into the brain. Now, there is varied evidence whether it works well or not, but other treatments are radiotherapy and a drug called temozolomide. Now, this temozolomide was a game changer. It came in 2005, and it essentially meant the survival increased from 9 months to 14 months, and that's a decent amount of time for cancer therapy. But it hasn't increased survival since then. Like, we haven't had any other options since then that have improved survival, at least. There are many therapies that are under investigation, but and they have improved symptoms and quality of life, but they haven't increased survival rates as yet. And that's just primarily because temozolomide was a revolutionary drug. It could go into the brain. Only 20% of the drug goes into the brain, which means if you take 100 milligram of the tablet, 20 milligrams will enter into the brain. So it's not a lot. The rest stays in the body and causes the side effects that we would experience from cancer therapy. So that is where my research comes in, and that is to develop how we can maximize how much of the drug enters into the brain, not just temozolomide, but other anti-cancer drugs that are used for other cancers, which do not go into the brain.
Yeah, and obviously it was a groundbreaking drug when it came along, but for people that have glioblastoma, to say that in fact your survival rate is now 14 months, I mean, whilst that is, and I'm sure everyone would want as many months as they could possibly get, 14 months is not a long extension in your life, is it, when you're suffering something like this? So, so talking about your research then, and what have you done, and what have you found out so far in regards to helping improve the absorption rates of TMZ?
Yeah, so my research started out with looking at those two barriers that are there, the blood-brain barrier and then the tumor barrier as well. So I wanted to design a formulation that could pass the blood-brain barrier. Now, blood-brain barrier is very, very small. I mean, very, very tightly regulated. So I wanted a particle that was really small. So I developed 30 nanometers, which is like a billionth of a meter, nanoparticles. And the challenge was people have made nanoparticles that are that small, so that wasn't a big deal. But the problem is that they need to be porous enough to carry the drug. And so I wanted, and then to have some sort of targeting ability, so they could go through the blood-brain barrier and then enter into the tumor. And so my first part of my project was to develop these nanoparticles. They're made of silica, which is a sand precursor. So, it's made from chemicals that are found in sand. But they have really high porosity, so about 70 nanometers in pore size. So they're really porous sort of material, and like a sponge, if you can imagine. And so they then are loaded with the chemotherapy drug, and then they're decorated with a substance called lactoferrin. Now, this compound lactoferrin is found in milk. It's a milk protein, but the receptors of lactoferrin are found on the blood-brain barrier and also found on the tumor barrier. So it's sort of a dual targeting substance. So if we have a formulation, it's simple. It's not a very complicated formulation, but it's the drug is loaded inside the nanoparticles, which are sponge-like, so it's porous. It can carry a lot of the drug, and then it can go through those two barriers and accumulate in the cancer. So my research has been to develop those nanoparticles and then to test them to see if that works.
So the best way then for a patient undergoing treatment still is to be able to take the tablets, is it, or is this drug administered in another way?
So we haven't tested in humans yet. This is still a very preclinical research, but I mean, for ideally, it would be ideal to take a tablet because it's most convenient for patients. But I've only developed it so far for injection. But that will be obviously a lot of work before it can get into human trials.
Yeah, absolutely. So what does your day look like in the lab for those that have never been in the lab and would like to understand? What's a typical day look like?
So it's kind of a mixture. Starts out with, there's a lot of reading before I enter the lab. In fact, you have to plan a lot of your experiments, because if you go into the lab and you can't just mix up chemicals and stuff, it's kind of, you have to plan a lot before you enter the lab. And then when you do, my every day will be making some of these formulations. So, I'm making all types of silica nanoparticles, and then analyzing them and testing them to see if they meet those criteria. So I measure its porosity, for instance, and or look at under the microscope, electron microscope. So not your light microscope, because they're so small. You have to use a very specialized type of microscopic imaging. What else? Yeah, I work with cells, so testing the formulations and seeing loading the
a couple of new guests. So I'd just like to welcome you to our Lunch and Learn today. I'm talking to Dr. Taskeen Janjua. She's from the School of Pharmacy at the University of Queensland, and we're talking about her groundbreaking work on glioblastoma treatment as well. So we've talked about, to recap, how a better way of getting drugs like TMZ into treat the tumours of glioblastoma through both the blood-brain barrier and the cancer tumour barrier as well. So you've said that this is right at the beginning of this research. What are you hoping, how long do you think this research will take, and when, if you can, and probably as how long as a piece of string, but when do you see it getting to the stage where, if the results are working, we might be able to do some preclinical trials?
So I've done some preclinical trials, but in humans, I think that will be the most exciting part of it. But we'll need to test them in advanced models before we can get into that. I've tested them in cellular models, and it seems to have very promising results. We published those results as well. But yeah, no, next step will be testing them in more advanced models before we head into humans. It's kind of a really hard question to answer, because one study dictates the other, and then so on and so on. And when we don't know which one will work, I mean, it may very well work in cells and, in the lab, but it's a different story when you start testing in, people, and yeah. So I can't answer that question. I don't know, but that's the whole research to test it and test it further.
Absolutely. So you've talked about also developing this drug which has silica and also some kind of milk particles from milk as well. Was that important to make sure that the bonding or the tablet or whatever formation it may end up being is as natural as possible? Because obviously, being in the body, you really want to limit the side effects as much as possible if it is successful.
Yeah, so that's exactly what it is. The milk protein is kind of a very safe chemical. It's not a lot of it is not found in our bloodstream, which means that it's not going to go elsewhere. If its concentrations were high, or if it was a particle that was, had other purposes, then it would go other places and it would cause side effects. Because its receptors are really highly expressed in the blood-brain barrier, and then also really highly expressed in the cancer, we would expect that it will accumulate a lot more in the cancer instead of going other places. And because of that, it would have less side effects compared to, without targeting. It also, this milk protein, I mean, it's because of its nature, and because of the way it's constructed, it's a large protein, and it only goes from one direction. It goes from blood to brain, but not back, which means it can stop the efflux that I was talking about. Our, blood-brain barrier has evolved to just check out all the toxins that can accumulate in the brain. So because it's only unilateral, it goes from blood to brain, that means it will accumulate in the brain and not be chucked out, which means that you'll have less systemic side effects, less toxicity around the body.
Yeah, lovely. Thank you. A couple of questions from the audience, and if you do have any other questions, pop them into the chat box below. One of them was about the side effects. So you talked about side effects from TMZ at the moment. What are the traditional side effects that someone might find from this treatment?
So temozolomide can cause heart problems. Just with like any other chemotherapy, it causes hair loss, gastrointestinal side effects. So by trying to targetedly deliver it, we can reduce the dose and also reduce the amount of side effects, because the dose will be reduced because you'll need less, because all of it will enter into the brain, into the tumor, and also because of its targeted ability, we'll reduce the dose. So those side effects could be mitigated by that. Currently, it's taken orally, so a really large dose is needed, because first it's taken by the mouth, then some of it goes into the stomach, and then into the intestines, and then into the bloodstream, and then it has to circulate throughout the whole body, and then enters into the brain. If we could target it and make it into a formulation, and it stays encapsulated in that formulation, then it will not go elsewhere, ideally, and so we could reduce the side effects as well.
Yeah, that would be fabulous, and particularly when you're dealing with children or adolescents. I imagine the impact of chemotherapy on a young child would be even more tragic than a grown adult as well. So very important. Lovely, thank you. Another question I have, which you probably know, but obviously our Australian of the Year, Professor Scolia, one of the most preeminent melanoma researchers in the world, sadly has glioblastoma at the moment. And there's a question here about how he had some cutting edge treatment with immunotherapy and passing the blood-brain barrier. How, you may not know the answer to this, but you know, how was that successful if the barrier is so hard to get through in existence at the moment?
So that's actually a very exciting field of research. But so this cancer is what it does is it reduces the immune response, and it causes immune suppression, and that's one of the reasons why it's so difficult to treat, because our immune system thinks it's a cold tumor. It doesn't go there. So there's this whole research of making these tumors from cold to hot, which means that our immune system will go and attack it. Naturally, I mean, if you have a cancer, your immune system should or ideally be able to, you know, take over and get rid of it. But because of the glioblastoma's ability to reduce immune response, we can't do that. So some of my research has looked into that. I haven't gone into detail into it, but one of the drugs I've used in past is doxorubicin, which is it's an immunomodulator. It can also activate the immune response against this cancer. I have tested it in some models, but in using the same sort of nanoparticles, just loading doxorubicin and testing it. The doxorubicin cannot go into the brain on its own. It's basically a very hydrophilic drug, which means it's very water loving. It stays in the blood. It does not cross the blood-brain barrier. So by putting in these nanoparticles, we can theoretically send them into the brain and test our immune response. Now, it's a very complex sort of thing to test in preclinical studies, so more research is needed from my aspect. But yeah, definitely that is a very exciting field of therapy, immune modulation, because our immune system can actually detect these cancers. It just, glioblastoma hides them from us. It just suppresses our immune response a lot.
Okay, thank you. One question here, which I believe is probably someone with a bit of insider knowledge. Will the new building going up next door to the School of Pharmacy have the right equipment for large-scale GMP grade production? Are you planning on using it in the future?
So I'm not aware of it. I've been on maternity leave for the last year. But silicon nanoparticles, the great thing about them is they're very relatively easy to large, increase the production. Now, we have affiliations with AIBN, which is Australia Institute of Bionanoengineering. And so we could, work with them as well to, increase the GMP large-scale production. That is a very interesting question. My research is not currently focused on taking it to that step just yet. It's not ready for large-scale production. But yes, definitely, if there's facilities, we'll definitely use them in future to synthesize more of these particles.
Yeah, lovely. Well, you got a thank you there and a smiley face. So thank you for answering that. A question actually I have, we're funding research and have in the past with neuroblastoma and copper chelation therapy. So for those that aren't familiar, what we find is that copper in the body hides the tumor, almost like a shield. And by treating it with a combination of chemotherapy and immunotherapy, you can actually break into that shield and start to treat the neuroblastoma tumor. Now, I appreciate that glioblastoma is different because it's multiple tumor sites, but has there been any research done on the impact with copper for glioblastoma in the same way as it helps grow neuroblastoma tumors?
Yes, there are some researchers in UNSW who are looking into copper, and there are people who work with copper nanoparticles, so it has a double function. The reason my research has been focused on silica is because it's very porous, and so you can load a lot of nanoparticles. It's also very easy to make, so compared to other nanoparticles. But yeah, no, definitely that copper is definitely a material of interest. You could also load them together, so combine the properties of copper with silica, for instance, and develop those nanoparticles as well. So there is a lot of avenues that can be discovered or worked on.
Yeah, lovely. Thank you. Just about 10 to 15 more minutes of our chat. So if any other questions, please do pop it in to the chat and I'll weave it into our conversation with Dr. Taskin Janjua at the University of Queensland. A question around little progress on this research for such a long period of time. Obviously, we talked about the evolution of TMZ and how that was such an incredible drug, but given that the survival rate is still so relatively low compared to other cancers, do you have an understanding of why it's been so slow to progress and actually us see results in glioblastoma research?
Well, the first reason is it's so diagnosed so late. Oftentimes the time for diagnosis is about 7 months, so the patients are already 7 months into the cancer. And then because it grows so relatively fast, it's really hard to get on with the aggressive treatments. But the main challenge, I think, why the survival rates have not increased is because we haven't been able to successfully overcome this blood-brain barrier. And so there's a handful of chemotherapies that can go into the brain. I think 3 or 4 I can recall from the top of my head that are able to cross the blood-brain barrier. And so one of them is temozolomide. So we need therapies that can target the cancer more effectively, and that is what's been the choking point at the moment. There's many chemotherapies available, but none of them can successfully enter and accumulate into the tumor, and that's been the most hardest challenge so far. There have been research on biologics lately, but their large size means that they haven't been effective. There have been many clinical trials with biologics as well, but yeah, their large size means they can't accumulate effectively into the tumor, which means they're not effective. So it's a very sad sort of situation where we are. In the last 30 years, we haven't increased the survival. We haven't, we've improved quality of life of patients, but we haven't cured it per se, or even increase survival from since the temozolomide came in. So yeah, I think the need is to develop therapies that can effectively enter into the tumor better, and also use multiple drugs, not just be limited to temozolomide, but use a combination of other chemotherapy agents.
Yeah, absolutely. Thank you. A question here about should your research, and I granted it's very early stage, be successful and it get to that clinical trial stage, would you find that this compounds, or whatever formulation it turns out to be, would be used in other cancers as well, or is this really just because it's so difficult to get into the glioblastoma tumor, you have to build it with the proteins and the silicon?
It can be used for other tumors, so especially other brain cancers, so meningiomas or astrocytomas, other brain cancers for sure. The particles that I've made, it's a step iteration. So you start with making the nanoparticles and then loading the drugs, and then decorating with the lactoferrin protein, for instance. We could change it to other proteins that are found in other cancers to target other cancers. The reason why my research specifically chose lactoferrin was because it was something that was, had higher receptors in blood-brain barrier and the tumor. But we can certainly, change that approach and target other cancers using these formulations. The other thing was the size of the nanoparticles was designed really, really small. Generally, your nanoparticles range from 100 nanometer to even bigger. But my choice of this nanoparticles was so that it was small enough that it would penetrate the blood-brain barrier. Now, there have been clinical trials which have used 10 nanometer silica nanoparticles for diagnostic purposes. So we know that 10 nanometers already goes into the brain. So 30 nanometers would also theoretically go into the brain. Now, it could be definitely used for other cancers as well, because their barrier threshold is a lot higher. So liver, you can have large particles accumulating in the liver. So yeah, definitely these nanoparticles could be used for others. You just have to modulate them depending on which cancer you're targeting and which drugs you would select for those cancers.
Yeah, makes sense. Lovely, thank you. Another question here on TMZ versus DOX. Do you think the timing regarding the possible immunotherapy combinations, e.g. Professor Richard Scolia, are highly important for avoiding immunosuppression?
Yeah, I mean, definitely, you have to time your therapies. Doxorubicin can cause immune modulation, and control that. So temozolom, it hasn't been tested yet, so I don't know whether we would test it like that. There's other therapies you would consider doing it with it, like interferon gamma alpha, for instance. These are all immune modulators. So you would probably use a combinatorial approach, especially because the cancer would rapidly evolve and develop resistance. So yeah, definitely you'll use a combination of them if you were to use them.
Yeah, lovely. Well, thank you. We talked briefly about one of the biggest challenges, obviously, being the blood-brain barrier. What other challenges do you find that you have in your day-to-day research work?
Yeah, so blood-brain barrier, and I think that's to do with the cancer. I think the other challenge is developing models in the lab to test them, because nothing can quite accurately mimic the blood-brain barrier as it would in a biological sense. So finding more accurate models to test them is a very tricky thing. There are now a lot of advances of organ on chip, and so they mimic the human biology on chips, and so that's a very exciting approach of testing them. I haven't done that yet, but I will really be excited to try them out on that. And then developing formulations that can theoretically pass those blood-brain barriers. So for me, my challenge was to develop something so small like that 30 nanometer, but also have that porosity that would enable it to carry the cargo. That was a big challenge. It took me a year to develop my nanoparticles. So yeah, no, so there's hurdles along the whole process, but the main two things will be to have the formulations that can theoretically work, and then having good models to test them in. But human cancer, it's a very dynamic sort of system, especially brain cancer, where you've got the barriers and then you have to test the efficacy. So it's not just to be able to pass those barriers, but also does it actually work? And I think that having those models is a key challenge.
Yeah, absolutely. And in regards to funding as well, obviously you're one of our new researchers this year, which is very exciting. How difficult is it, particularly when you're an early career cancer researcher, to get funding?
Oh, it's definitely the hardest thing. I mean, half the time you're writing grants and thinking about, okay, what's going to happen next year, and the other half you're focused on doing your research. So it's really distracting to be working on trying to find the next year whether I'm going to continue my research or not. And that's in an ideal world we wouldn't have to worry about any of that. We would just be focused on our research. But unfortunately, that's the reality. You have to keep looking for grants to continue your research.
Yeah, absolutely. And then from a collaboration perspective, are you working with any other units across Australia or internationally on this work research at the moment?
Yeah, one of my collaborators is Professor Maria Kalularis from UNSW, and also Professor Chris Tursky from AIBN in UQ. So they've been really great in mentoring and guiding me on different sort of models to work with. Professor Maria Kalularis has been amazing in mentoring me throughout my candidature, actually, and I've worked very closely with one of her PhD students, and so I would make the particles, and we will send them over to UNSW, and they would test them in their models. And that has been a really successful project, because we got so much data out of it that we wouldn't have if I was just solely working on it. So collaboration, I think, is the most important aspect, because while we can become experts in one field, we cannot understand the whole cancer and all the different difficulties it presents. So that has been really amazing to work with such leading scientists.
Well, that's great to hear, because Professor Kavlaris is also a Cure Cancer alumni, so we funded her probably about 30 years ago. So it's great that you're working with her as well, part of our our
He's
research
amazing.
alumni.
He's amazing. Yeah.
Wonderful. One of the questions here about glioblastoma and the type of cancer it is. So often we hear from researchers that certain cancers like throat and head and neck cancers are heterogeneous, so they change within and they can change. Is glioblastoma typically the same in most patients? Is that a challenge you have to deal with, or is it very similar for most patients?
Oh no, it differs quite a bit, and it can predict a lot of whether there will be a response to therapy or not. For instance, even with temozolomide, a lot of patients develop this methylation. So one of the genetic factors on the cancer changes, and that means the temozolomide might not work for those patients. And I think that is an approach in future that we need to take, to understanding the cancer of the specific patient, and then developing therapies for those. So basically a personalized sort of a cancer approach. And there's been a lot of work on it. And now we're starting to understand the different sort of differences between the cancers in the patients. And it has made a difference to some degree. But we need to, yeah, I think it's a very heterogeneous cancer, and it changes rapidly as well. It's even with the treatments, you're giving one treatment and all of a sudden it will change shape and form. And so yeah, no, glioblastoma is one of those tricky ones.
Yeah. Okay. Thank you. Question on your hopes for the future. Obviously, you're looking at these nanoparticles now and how to test them and formulate them in an appropriate way. But in the long term, what is your hope that you have some form of substance that you can give that's more effective in treating, or is this actually looking at this may be able to cure glioblastoma itself? Is it more of a treatment plan or a cure that you're looking at?
I think it's a treatment plan. We're not there yet to say that we have cured brain cancer. It's unfortunately that I wish I could say that, but no, we're not there yet. But I envision a future where we find better ways to treat glioblastoma, especially considering its complexity. This means we'll have to develop therapies that can target different aspects of the cancer and figure out how to get those treatments to the right places in the brain. I also hope we can harness the power of body's immune system, so to help fight the cancer is what something we had discussed before about immunotherapy. So often this is a very cold sort of tumor, so maybe if we can activate our immune responses and alert them to this cancer, that would be ideal. But ultimately my goal is to see these efforts lead to a longer and better lives for people with glioblastoma.
Yeah, absolutely. And sadly only 5% survival rate over 5 years. I think any significant improvement you can make for that will be very gratefully received as well. So before we wrap up, any last words that you'd like to share with our audience today, Taskeen?
There's always hope. I would say there's always hope.
Yeah, lovely. Well, thank you for your incredible work. Oh, sorry, one more question before we wrap up. Have you considered using the focused ultrasound system, which is in the basement at UNSW, to test whether uptake would be further boosted?
We have considered, we haven't tested yet, but we have plans of testing that in the future.
Lovely. All right. Well, thank you on behalf of everyone here. And our generous audience that has helped fund your research grant. Thank you for your work that you're doing. It is very much needed, and the innovation that, be fair to say, and the time and consideration and developing that nanoparticles, it's incredible work. So I'm sure you don't get told thank you enough, but we really appreciate the work you are doing, and in the hope that we will get to some clinical trials in the near future once you've finished all your tests as well. So thank you for all that you are doing for glioblastoma.
Thank you. Thank you for your support.
No problem. And thank you to our audience for being here today. Please join us at the same time on the 13th of June for our Lunch and Learn with Dr. Peter Georgeson. He's at the University of Melbourne, and we'll be talking about his pioneering work on bowel cancer. So until then, stay safe and we'll see you soon. Thank you.
Thank you.